Welcome to the webinar of the Geriatric Emergency Department Collaborative. My name's Don Milady. I'm an emergency physician in Toronto, Canada, and one of the core faculty with the Geriatric ED Collaborative. Our topic this afternoon is one that's probably new to some people, and that is community paramedicine and how it can interact with the geriatric emergency department. For some people, this will be a completely new topic, and you'll be here to get new ideas and explore what this field can mean for you. For others, you're working in the system and in the field already, and we'll be interested in hearing your experiences also. The term means a lot of different things, and so we've put together a really great panel today looking at presenting models and examples and stories from many different ways that community paramedicine can exist. So we've got 3 countries represented, 3 different disciplines here, and 4 distinctly different models of community paramedicine. So I do hope that you'll get something from it. We will have many resources for you if you're interested in exploring the field further, including on our the GEDC website. There's a recent blog as well as a podcast coordinated by Dr. Christina Shenvi, which will give you some interesting points, especially also about training, which is also always important. Next slide, please, Heather. We have about 220 people have registered for this webinar from 10 different countries, the United States, North Canada, and around the world. We asked you, when you registered, what things were important to you or how you thought community paramedicine could be helpful. And these are some of the answers that you gave. Interestingly, a lot of people said, I don't know, I'm interested in finding out. So some of the interesting things I saw on the list here was this idea of anticipatory care, of not waiting until a problem exists, but doing stuff to prevent problems or solve problems earlier, providing education, assessment. There's a lot of assess on there. The number 1, which appears at the top of the list, is avoid ED transfer. And I always like to add, avoid unnecessary ED transfer, because when you need to go to an ED, it should be there. But if you can avoid it, then that's certainly best for everyone. We have a very diverse audience on the webinar today, clinicians and administrators from all over the world. As we're getting started, could you please put into the chat, after you select from chat, select everyone, so that everyone can see. Let us know where you're calling in from and what your role is there. Next slide, please. The Geriatric Emergency Department Collaborative is a network of members of community and academic emergency departments from around the world, principally in the United States, and we have a significant number internationally. We work together to define the best practice for older people in emergency departments. We educate clinicians about those best practices. We help clinicians and healthcare systems implement them, and we research outcomes. If you share this vision, we are accepting members for free. It's the best deal in the world. You get access to all resources available on our website and through a network of experts, and all of that for free. You can download the application form at the QR code there. If you'll be learning a lot about how to implement community paramedicine today. So if you then wanted to be in further contact with people who have done it internationally, you would be able to link to a network of experts through your membership in the GEDC. Next slide, please. Before I introduce this panel of 5 experts, just keep in mind that this is your chance to talk directly to somebody with a lot of experience in community paramedicine. So start thinking now about questions that you might have for any of the panel, and please enter them into the chat. We hope that there will be time even as we go along, and certainly at the end, to address some of your questions. So we would urge you to use the chat function to let us know what you're most interested in finding out about. Our, previous slide, thanks. So Dr. Jose Cabanas is our first guest. Jose is the Chief Medical Officer in Wake County, North Carolina. Significantly, also, he is the president of the National Association of EMS Physicians across the whole United States. He's also a leader, researcher, and educator in the field of emergency medicine services, and is also on faculty at the University of North Carolina. Dr. Neil Dattani is an emergency physician in one of the suburbs of Toronto, Canada, where he works both full-time as an emergency physician, but he's also the clinical lead for a community paramedicine program in a very large region of the Greater Toronto Area. Anne McDermott is joining us from Dublin, Ireland. She's a master's prepared paramedic who works in Dublin. She helped create and still works in their community paramedicine program. Michael Stern is an emergency physician in New York City. He's the chief of the geriatric emergency department at New York Presbyterian Hospital, and he's the lead of their community paramedicine program. And finally, Maria Wesloh is an Air Force medic and who now works as an implementation specialist in the Veterans Administration supporting their community paramedicine program. So as I said, we've got an excellent panel of experts here. If you've got questions or comments as we go along, please let us know what those might be. So we can leave the PowerPoint deck at this point, and I'm going to turn the first question to Dr. Cabanas. You are pretty knowledgeable about the whole paramedic system across the United States. I'd like you to kind of introduce us to the field, keeping in mind that there are some people working in community paramedicine and some people who have probably never even heard the term. So how would you define the broad field of community paramedicine?
Thank you, Don, and good afternoon, everybody. Thanks for being here, for your interest in the community paramedicine sort of programs. It's really a pleasure to be all here with all of the great panelists. In essence, community paramedicine is a kind of, think about like a new service delivery model within a community that seeks to improve health outcomes or enhance health outcomes for specific patient populations within that community. And it leverages the EMS system sort of clinicians that are trained and prepared and available to care for the community, but in a different way. So a lot of communities across the country have been looking at leveraging sort of their EMS clinicians who have a very unique expertise, accessibility, and capabilities to try to better serve their community through a new enhanced service delivery model. That's in essence what I think about community paramedicine. You will hear the term in a lot of different ways. You can hear some people talk about mobile integrated healthcare, or MIH. Others may refer to it as advanced practice paramedic, or the more now sort of, I guess, established sort of concept is community paramedicine. So that's sort of in essence what I would sort of define it.
So this is moving well beyond the old-fashioned scoop and run view of a paramedic, of using the skills that they already have, which as we as emergency physicians, emergency clinicians know are very sophisticated, using them to do other things. What are some of the other things that you've seen people implementing across the states?
So in essence, most programs in the country and some around the world, most of them have been built around a specific need for their healthcare community which they're working and serving in. For instance, our program in Wake County which has been in play probably since 2009, initially developed based on the ongoing need to find a better way to serve our most vulnerable, in essence, around mental health and patients suffering from addiction. That was our initial patient population that sort of helped us sort of build our initial advanced practice paramedic program, which is also our community paramedicine program. Now, from there, it has evolved into other domains and other patient populations, like, for example, our elderly patients that have frequent falls in assisted living facilities. So across the country, it has developed through different domains based on the needs of that specific community. So you will see some programs that are mostly around mental health, others around geriatric patients, others around hospice care, others around substance use and treatment needs, others around familiar faces or patients that are socially very vulnerable and need additional services. So it's a different sort of programs across different needs of those communities.
Can you give us some examples? So thinking of the fall for those folks interested in older adult care, falls comes to mind immediately. What are some of the things that you've done at your place around either falls assessment, falls prevention?
Absolutely. Absolutely. Yeah. So one of the things that we learned several years, it's probably around now, probably almost a decade now, we were noticing, like I'm sure many of our colleagues here, many systems are, that we were seeing more frequent calls for elderly patients who were having falls at assisted living facilities. And unfortunately, a lot of these facilities, because they're worried, they're concerned, they typically, from a risk mitigation standpoint, they call 911 because they want to make sure nothing adverse is going on and so forth. So as you all know, EMS systems had very limited options once they engage with a patient that may have medical problems, chronic medical conditions, elderly, and so forth. So we were noticing, like, can we do something different? And at the time, we were able to engage a primary care provider who, of our log, had a lot of the sort of assisted living facilities in the community. So one practice was already sort of embedded into a lot of our assisted living facilities in Wake County. So we went to them and say, hey, can we find a different way to provide services to your patients? And they said, absolutely. We don't know why they have to go to the ED all the time. So we worked together on developing a protocol to better manage patients once we encounter them. And in essence, we developed a shared decision-making protocol that has several different tiers. We developed the protocol together, and then we did a kind of retrospective on-paper review of how it would perform, and we published that. Once we published it, then we developed prospective validation of that protocol. In essence, it's very safe. We have a specific, without getting to all the weeds of the protocol, I'm happy to send it to whoever wants it or needs it. But in essence, once we respond to a call or somebody has a fall at a assisted living facility, we have several tiers. Sort of like, think about green, yellow and red, right? So red clearly has to go to an emergency department, fracture, open injuries, those kind of things. Somebody who is sort of a clear cut, no need, like a slip of the wheelchair, bump my knee, that kind of thing, don't need to go. But then you have a middle where things may be a little bit murky, so we engage in a consultation with an on-call physician for that group with specific guidelines about, and when with the patient and family, do you want to go to hospital or can we arrange care here at the facility? And it has worked tremendously well and avoided significantly number of ED visits, and patients are happier and families are happier because they are receiving care where they are, and the group was able to accommodate and ensure they were having timely follow-ups with patients. And that's at a high level, but I'm happy to provide more details if needed.
So clearly, I think anybody would say this sounds like a great model. I'm going to ask the two complicated questions that I think everybody is in everybody's mind when they hear this. And can you talk about some of the regulatory challenges? So how do you get this implemented? And then just some perspectives about funding and where the money can come from, what the costs, big costs associated are.
Great questions, and I will probably need a whole webinar to talk about funding, but but in essence, one of the very unique things about our community paramedicine program is we build it from the beginning as part of our embedded response within the EMS system. So it's part of our readiness cost within the EMS system, because our community paramedicine program not only manages some of these specific programs, they're part of our regular response for calls. So there are three kind of elements to our program. One is sort of respond, reduce, redirect. So our paramedics respond, our APPs respond to high acuity calls, because we want a number of paramedics that see very sick patients on a regular basis. So that creates additional proficiency, skill, and comfort level. And then we're not doing that. They are doing all the other activities within a community paramedicine program. So they're embedded into our service readiness response for the EMS system. Having said, yeah, go ahead.
So some days the paramedic may be going to major vehicle traumas.
Sure.
And the next day going into a long-term care home.
Right. Yeah, absolutely. So they may respond now to a cardiac arrest that they have to manage, and then the next call may be helping with somebody who needs buprenorphine treatment for addiction, or the next call may be dealing with a fall in the facility. So they are embedded into the regular EMS response. So from a readiness standpoint, it's part of that cost, which is a challenge for some programs across the country, which have been built with grants or not part of that EMS system readiness response, because then you don't have sustainability funding for the model. And in this case, the FALS program that we have in play, that have been in place for a long time, we don't get reimbursed for those activities. Now, in the United States, EMS is a supplier of services, not provider. So because we don't transport that patient to the ED, there's no reimbursement for the EMS system for those clinical activities. Recently, CMS put out a pilot on ET3, which we're part of, and under ET3, we're getting billed or reimbursed for those activities, but that is transitioning away. So in essence, it's a challenge to be able to sort of sustain it long term, because the more activities at a high level, an EMS system, the most in the United States, any activities that you do that don't require a transport to an emergency department, what you do over time is you lose your ability to recover some of those costs. So then your tax subsidy or anything else needed goes up over time. And that's a different conversation but that's what we have to consider when you build your programs.
Okay, and maybe we're going to have to wrap up in your segment, but the whole regulatory thing of how...
Oh, sorry, yeah, missed that.
If you can make a few comments about that, how do you transition to expanded scope of practice and that sort of thing?
Yeah, very good question. So obviously in North Carolina, all these activities that we do in our community paramedicine program are already sort of accepted within the scope of practice of our EMS clinicians. There's nothing sort of new there. As a medical director, you have to make sure you're doing the right training, the right quality assurance and performance improvement activities, and they have the right protocols and clinical guidelines to support that practice. So in essence, that not a challenge there. Some other states have problems with regulations around being able to disposition patients or transport patients to non-ED settings. That was not a hurdle for us here in North Carolina. We needed to do a lot of work with our assisted living facilities to make sure there was coordination, collaboration, and comfort level with a different approach to care that they were not used to. And that took a lot of time and effort. So that's something that was extremely important, more than the regulatory piece in North Carolina.
Good. Thanks, Jose, for those broad perspective on the field. You're staying on the line. And please, as you hear about the other models that we're going to hear about, put your observations into the chat or ask questions. We'll move north now up to snowy Toronto, Canada. Dr. Dattani, you work close to where I am now. And it seems to me that your program is what people would think of as kind of a classic community paramedicine program. Can you tell us about how you've set it up and what kind of services you offer?
Absolutely, and it it really builds off a lot of what Dr. Cabanas said. I think you have to have an identity with the program when you're setting it up, and there are a lot of different options and directions you can take with that. And as he said, very correctly, you do have to be responsive to the population that you're serving. So what we decided was we were going to target specifically an older patient population. So we serve specifically patients 65 plus. And I think the other part of planning out a program is which care partners are you going to align with to develop an overall purpose for your program. So in our current state, we are an after acute care hospital visit service. We ensure adequate follow-up, reduce the risk of bounce backs, and ensure a seamless transition back into the community. That's our primary identity. Now, as we have been in this state of our existence for approximately 2 years, we have evolved a lot, responded a lot to different needs of our community, but that was how we initially set out to plan our program.
What are the new things, when you say you've evolved from what you thought you were going to be doing, what are some of the things that have got added on?
So a very exciting big addition, and similar to Dr. Cabanas, I don't want to get too much into the weeds in my 7 minutes of allotted time. I'm happy to take any further conversations offline, but we leverage the significant knowledge, skills, experience, abilities of paramedics to really practice to their full scope. So we are just on the cusp of launching medical directives, advanced medical directives, whereby our community paramedics can do bladder scans, IV starts, IV medication and fluid administration, in addition to the full complement of assessments that they've already been doing. So that's one example of how we're taking it to the next level. And there are so many different ways that you can grow, given as we've mentioned, the significant abilities of these paramedics. And we're excited to take this to the next step in our program.
So can you give us some examples of some of the things? So as this is mostly follow-up from admitted patients discharged from hospital, what about the connection with the emergency department?
So we certainly also follow up from ED visits. So it's either ED visits or after an admission. We find that a lot of the patients that we have the most to offer to, at the time they're presenting to the ED, they're usually quite sick and do require an admission to hospital, at least a short admission, but we're able to facilitate hopefully a sooner discharge from hospital, or at least give confidence to the hospitalist providers that they're able to discharge. We do identify as a future priority a situation where we are more responsive to the ED to the degree that we can actually avoid those admissions in the first place. And that is exactly how our medical directives have designed to be, providing services, advanced therapies that currently there is no access to in the community. And we believe that will give our program a further identity that is able to avoid admissions. So we currently are responsive to EDs. I think up until now, we have been most relevant to post-admission visits, but we do see a future state where we are equally as relevant to EDs.
How would an ED, what's the interaction between a community paramedic and the ED? How does that communication happen, going either way, either from the emergency department or from the community paramedic?
Well, I mean, from the ED to a community paramedic, we accept referrals. So it could be, just a general referral process, or if there is the need for a phone call, we are accessible. Going the other way, it really is one of our mandates to avoid ED visits whenever possible, avoid relying on the acute care hospital system. So all of our paramedics are trained and have experience in the 911 stream. Somewhat different than the program Dr. Cabanas was describing. Ours are full-time community paramedics, so they are fully working in our stream, but they still do have those the knowledge and skills of working in the more acute care stream. So when necessary, if there is a patient deteriorating, they'll follow normal protocols, nothing unique. And again, the other way, we are responsive to EDs to the degree that they need us.
So if would a community paramedicine in your program be notified if there was an acute 911 call?
No.
No, so that would
Now,
be.
but that is a very good point. One of our, one of my takeaway points that will be circulated afterwards, I'll highlight now. I'll take the opportunity to state that when designing a program, one of the other very important things is to identify your referral sources. That does relate closely to who your clinical partners will be, but it's thinking about it a little bit further. And in our experience, one of the really helpful things as we set out to start our program was accepting referrals from the 911 stream of paramedics. Because we are a separate program to the 911 stream, but still within the same overall service, our EMS service is still one service, we are able to have very close communication with 911 stream paramedics. So what we find is that we have a very large volume of referrals from our 911 paramedics. The patients, they are obligated to take the patients to the ED, but if they identify themselves a role for us, those referrals can be made. And in terms of the benefit to our service, it provides us with a steady stream of high-level referrals, as opposed to strictly depending on external organizations where there can be sometimes changes in priorities. We found that to be extremely helpful, and continues to help us to develop our identity.
So you like it when so a person falls and has an injury and gets taken to the emergency department, but that paramedic transporting also has the means to contact your program and say, you guys probably should go in and take a look at this subsequently. That's the kind of thing that happens?
Absolutely. And in those cases, we do have a process to see if they are still admitted, if they did go home. Obviously, there are some logistics to figuring out what happened after the fact, but we accept those referrals and we follow up with them. Absolutely.
So just moving on in the last minute here to issues of training and education. You said all of your folks are full service advanced care paramedics. What did they need to learn new and different? What are some of the skills or abilities that they didn't have that they needed to learn?
So this is a little bit of specifics, but they're not all advanced care paramedics. But I know this is an international audience, so I won't get into the levels of paramedicine in my area. But similar to Dr. Cabanas, a lot of the fundamental assessment skills that they have come from their general experience as 911 stream paramedics. Now, specific to our program, at the launch of our program, we based our specific assessments on a comprehensive geriatric assessment. So a very standard comprehensive geriatric assessment, actually, and that would be the additional skills that they initially received, the ability to provide that more robust history and look into things in more detail from a geriatric focused lens. Since then, we have evolved into further training, point of care labs, the advanced therapies. These all require a significant amount of CME and a lot of hands-on training and sessions and clinical placement. So that's all directed to where we decided to take our program. But fundamentally, it was the skills that they already had in the general stream and adding on the comprehensive geriatric assessment.
And just final question, back when the program originally started, how many community paramedics did you start with?
We had between 11 to 12 full-time.
Good. Okay, thanks a lot. Now we're going to go across the Atlantic. Anne McDermott from Ireland. You have another classic model of community paramedicine, which is actually quite different from that one. Can you tell us about the way things work in your system?
Sure, yeah. Good afternoon or good evening, everyone. Just briefly, how we started was 2017. We got some EU funding with Scotland and the Northern Irish Ambulance Service. So at that stage, we were able to train 4 National Ambulance Service paramedics, or advanced paramedics as they were. And that was to master's level education in Scotland. A lot of extensive time placements with general practitioners or family physicians, GPs as we call them. And then that kind of developed, that model was kind of followed on by the National Ambulance Service themselves with their own funding in 2020 to train a few more. And now we have another class running at the moment. So we're currently about 7 or 8 staff on the road. And really what we do more or less is respond to EMS calls, low acuity calls.
You're the first responder.
Generally, yeah, and also, so it's low acuity calls that we would be dispatched to, but also higher acuity, either as the closest resource available, or as a crew request. So if a crew is with the patient that they still feel is suitable for us, they would request us as well.
So what kind of calls do you then, when you say low acuity, how do you determine that? Who determines it? And what do you do when you get there?
Yeah, so it would be determined by the AMPDS system, which a lot of EMS systems use as their triaging over the phone. So when a call comes into our control center, if it's low on the triage system, then it would come to us that way. That's how most of our work comes to us. We're also tied to general practitioner practices that we would kind of train with and have a continuous relationship, and we would do some of their house calls as well, but that's just specifically for our partners that we're partnered with through the ambulance service.
So when the 911 call or equivalent comes into the dispatch center, the dispatch taker takes enough information to determine that we probably don't need to send a car and a crew, but rather we can send somebody from the community paramedicine program. Is that right?
Yeah, absolutely.
So then what kinds of calls are you getting, and what kind of value do you think you're adding to those calls?
So we get traumas, we get minor traumas and medical and surgical cases, I suppose. We go to all age groups, but our average age that we attend is 62. Life expectancy here is 82 at the moment, so quite a high life expectancy, and it's growing, and we've a reducing number of GPs as well. But we do go to all ages. We would also, as I said, attend some of the higher acuity calls, and we can discharge on scene if it's appropriate with those. And we actually discharge about 42% of the higher acuity calls that we attend as well.
Can you give an example of that? Seems striking to an emergency physician.
Yeah, I suppose probably
Get a
best.
high acuity call and it doesn't even need to go to the emergency department?
Yeah, so I suppose some of them are wound closure and things like that. But a lot of them are probably respiratory calls. They're the COPD patients. They come in as high acuity because there is no low acuity respiratory call. And when we're there, we're able to deal with that on scene.
So this sort of sounds like an urgent care clinic on the road. Is that accurate?
Yeah, and also a jack of all trades. I think we do a bit of everything, from the baby with the thing stuck in their ear to the elderly person with fall or UTI or whatever it is.
Mm-hmm. So
Yeah.
what do you hear back from either your clients, your users, or from other parts of the system, the emergency department or family primary
Yeah,
care?
I guess the ones that we do get to discharge at scene are delighted. Obviously, they rang for the emergency because they didn't know what better to do or didn't think they had an alternative. So if we can discharge them at scene, they're great. We would also use patients' own transport. That's another decision we can make, is that they do need to go to the emergency department, but they can wait for a relative to bring them or something like that. So we there's about another 10% of our calls don't go by ambulance, but still get to the emergency department. So that's always nice. The emergency departments appreciate somebody making their own way, but having been fully assessed on scene by a community paramedic. And then for the ones that go in, I think we kind of have local arrangements. So we would try to pre-alert the frailty intervention team or whoever is in the hospital, if we can, about maybe fast tracking the patient through the emergency department, particularly the elderly ones.
So you do have a direct communication to the emergency department?
Yeah, on a sort of an ad hoc basis, depending on where we work. Like where I am, I would deal with 8 different adult emergency departments in my catchment area, whereas some of my colleagues would deal with 1 or maximum of 2, depending on just where we're based. I'm in Dublin.
So, I mean, this is interesting that these two programs are kind of diametrically opposite.
Yeah.
Neil sees only people in follow-up. You don't see anybody in follow-up. You see only people in the acute call.
More or less, yeah. Maybe on a case-by-case basis, we would try to follow up, but we don't make specific arrangements to do that. We're dispatched by the ambulance service primarily, and we need to be available for those calls.
So same question as for Neil around training. You alluded to that they were kind of seconded to primary care offices.
Yeah.
But what kind of skills did the already well-prepared paramedic need to learn to do this job?
I think like skills wise, there's not a whole lot. We did do urinary catheters, we've done wound closure, and a few other little skills, but the biggest difference is autonomy. So learning how to make those decisions, and that's what we needed the supervision for, and all the time with general practitioners was just to learn how to make clinical decisions, evidence-based.
Yeah, good. And so just as we're wrapping up, I did want you to tell our audience about some of the research and framework that your Irish system has come up with that might be valuable to other folks on the call.
Yeah, so our regulator, who's PHECC, PHECC, the Pre-Hospital Emergency Care Council, we worked with them. So the Irish community paramedics and a lot of international collaboration worked to develop a framework that sets out the education, all the standards, the drugs that we would hope to use, everything that's needed to be a fully functioning community paramedicine system. So we published that last year, and it has been quite well received. There was a lot of international evidence went into it, and that's all there available for free. And I would certainly recommend looking at that if you're looking at developing a system. I think the biggest thing though is that no two areas are the same, and really you have to just tailor it to your local environment as you go.
That seems to be a recurring theme here.
Yeah.
So thanks. We will put the link to that very valuable document in the chat as well. And I noticed there's a question wanting to know more about the frailty intervention team, which is the subject of yet another completely different webinar. So we'll invite you back at that time. But for now, we're going to move back to the United States. Thanks a lot, Anne.
Thank you.
Maria, you're from yet another model of community paramedicine specific to the Veterans Administration. So can you tell us about that?
Yes, our program is called SCOUTS. It's Supporting Community Outpatient Urgent Care Telehealth Services. And this is based around the practices of a military medic, which is our ICTs, or Intermediate Care Technicians. They work in the emergency department. So the ICTs are prior service medics that are either still serving as reservists or have gotten out of active duty military and have now either retired or separated and now working as ICTs in the VA. So our scouts come about, what we do with them is they start from the emergency department and we screen our geriatric veterans who are 65 years or older. And we do about 5 questions identifying seniors at risk. And when they pop positive on one of those screens, we do a deeper dive and do a geriatric screen. So from there, we decide is it a falls risk or what's going on with this person? Is it a medication thing? And that's when we get pharmacy involved. We have physical therapy involved, but that triggers a scouts visit where we go out to the patient's home and do some follow-up care. So it's either they were too sick to be admitted into the VA, but sick enough to where not sick enough to get admitted, but they got sent home. And so maybe we can do some follow-up care to make sure they're okay, like in a couple days. Or was it a suture removal and they have a hard time getting to the VA, have some functional decline. And so we'll go over there and remove those sutures for them to keep them from coming back in the ED and being exposed. Or is it a falls risk? Has this person had several falls in the past few months and we need to go follow up and see what's going on at their house? Or do they have tripping hazards? Is Are their living conditions bad? We bring social work involved in this. Also, we have physical therapy. So what the scouts do is they go out to the home and they are on an iPad with a licensed independent practitioner, whether it be the emergency department physician or one of the emergency department physician's assistants. And so we have them on the whole time while we're going over vitals and we're assessing the home or assessing the patient. And so we come up with a plan for that patient. Do they need more? Do they need a walker in their house? Do they need canes? Do they need a walk-in shower? Were they falling? Do they need rails? We start from the very beginning of the house and go from the front porch up until we walk into the house. Do they need a ramp going up to their house? Do they have steps? Do they have rails that are shaky? Those are the types of things that the scouts are looking for with physical therapy on board the whole time, watching, and with the provider, which is our LIP, the licensed independent practitioner, on while we're doing this whole thing. And that's when we come up with a plan. Now, sometimes our scouts visits can be another scouts visit post that. Let's say if it was an incision and draining and they had packing removed and it had to be repacked again, and they need to follow up again, and that veteran can't get back into the ED. That's why we're here, so we can go and do that follow-up care.
Great. I just so this ICT, intermediate care technician, works both in the emergency department with older people, and that's your Geri Vet program.
Yes.
And they could also work in the community program, that's the Scouts program. Could they ever be the same person, like where does the same person work in the ED and work for Scouts?
Yes, so we do both. So it could be the same ICT that screened them that's going out to do the scouts visit. So we schedule these scouts visits, and depending on if they got admitted or if they're going straight home, and then we get with them and say, okay, we want to come out to your home and we'll schedule it out and just make sure they're good to go and have all the information. And then it could be the same ICT or it could be somebody else, but we do a nice little warm handoff to the next person who's going to be taking care of them, because we already have it scheduled out with all the scouts of who's going to do what day.
That's a level of continuity of care that very few emergency departments in the world can provide, and it's the complete opposite of the famous meet 'em and street 'em model, where you don't have any follow-up at all.
Yes.
What again, going back to the training issue, what did you find, Maria, about additional training required even to take the ED-based ICT and turn her into a scout? What other things do they need to know?
So what we do for all ICTs is all of our ICTs go through a foundational intermediate care technician training, and we hold that. It's a 40-hour pre-course module that you're doing just on, which is our training module system, computer-based training. And then they have a 36-hour face-to-face, and we're running that course out in Fayetteville also. So they learn how to do the Geri Vet screenings and how to do just the beginning parts of that. And then the additional training after they graduate from that course, they move on to do home-based primary care ride-alongs. So we see how home-based primary care does their thing and how to bring the bag in and keep it sanitary, not contaminate it. What to do, taking vitals with the patient, how to dispose of any waste that we come in contact with, and just it gives you the ins and outs of doing a care in the home. And then on top of that, we have other competencies that we have to get checked off just at the home of doing vital signs in a patient's home. It's not any different, but it is because we have different equipment that's going to go with them that we don't have in the emergency department.
Great. So what do you hear back either from your scouts or from the patients that you serve? What do you hear about their response to the program?
So the scouts love it. They are very, it's a very passionate thing for them. And they just love to have that one-on-one contact and to see that from the beginning to the end that they're making a difference with this patient. And the patients are, it's that veteran to veteran camaraderie that we have. They seem to be a lot more receptive to another veteran taking care of them and going to their house, whereas a civilian's coming to their house, they're very not about that. They're very pushback on that and say, I don't need you at my house. But when we build that camaraderie in the emergency department and say, hey, we're going to have one of our scouts come, another medic in the military, they are all about it. They're more receptive. So we've noticed that it's just been a high patient satisfaction with having this program. And we've had so many thanks from the veterans themselves and said, we've never had anything like this. The follow-up is amazing. We didn't even have to go in. Some of them say, I can come in. And we say, nope, we're going to come to you. And they're like, I feel like a king. And so I was like, that's the point. We want to make you feel special and make you feel like you're being taken care of.
Great. That's, I think everybody working in an emergency department would like to be able to have that feeling about care that they provide to anybody, particularly their older patients. So thanks a lot, Maria. If you've got, I think there is some additional information in the chat about the Scouts program. So now we're going to move to downtown Manhattan. Dr. Stern works at New York Presbyterian, and there's yet another very interesting model here of adding a whole technology component to a community paramedicine program. So Michael, can you tell us about your program?
Certainly, it's a pleasure to be part of this panel. So ours is called CTP, which stands for Community Teleparamedicine. And it's a fairly unique program where paramedics go to the homes of high risk, high utilization patients, predominantly, overwhelmingly advanced heart failure patients, most of whom have been recently in the hospital, even discharged directly from the ICU. And when they get to the home, they then log on via telemedicine with one of our ED physicians who has been trained in telemedicine. And so we're leveraging the pre-existing telemedicine care delivery platform that started in 2016. And thankfully, it was well in place with regard to the technology and the knowledge of the practitioners using it for COVID, because that was a huge, a benefit to the hospital and the patients. But we use our telemedicine faculty, who are regular emergency department faculty and have a certain subset of their shifts in telemedicine. We use them specifically for CTP encounters. And the goal is to reduce both ED revisits, and there's actually a 40% reduction in ED revisits, which is astounding, as well as hospital readmissions within 30 days of their index heart failure admission. And that's a 25% reduction, which the hospital obviously loves because there's a real significant cost savings as well. And what we do is we utilize a comprehensive visit approach that incorporates complete physical exams, medication administration intravenously, occasionally even changing milrinone drips that are pre-existent in these patients, medication reconciliation, and actually ancillary services that are set up, such as home blood draws, durable equipment orders, et cetera, using our CTP care managers. And so it's a very sort of vibrant and real-time exchange that keeps these patients out of the hospital. Each CTP patient, when matched against a cohort that's similar, saves the hospital between $3,000 and $4,000 within that 30 days after their initial admission. And that includes the cost of the CTP program itself.
Wow, that's pretty compelling. It can't be hard to make an argument in favor of this program with those kind of numbers available to you. What do you think it is that your folks are doing? Like, you listed a bunch of things, blood draws, waits, whatever. What's your general impression of the thing that your folks are doing that makes that big difference in decreasing ED returns? Because at our end, it just seems like everybody comes back. So what
Sure.
are you doing?
So it is in classic geriatric care form, it's multidisciplinary. So first of all, we have real-time coordination. I mean, during the encounter, whether it's via phone call or a secure chat over the EMR with the heart failure doctors and NPs, so part of the heart failure team, with our CTP care managers, so we can make adjustments in real time. We're working with very, very skilled and compassionate paramedics who've received extra training, who do a pretty much a comprehensive exam. They've been trained in wound assessment, granular description of lower extremity edema, even bedside ultrasound to assess for pulmonary edema. They obviously take vitals and weights. They do a medication reconciliation. They assess the psychosocial issues that are part and parcel of someone who's got a critical illness such as advanced heart failure. And so it's very, very comprehensive. And if it is deemed during the encounter that the ED physician and the paramedics together feel that this patient actually is too unstable to manage, even with all of these advanced things that can be done at home in real time during the encounter, a warm handoff is given right then and there to our colleagues in the ED via the EMR, and they're brought directly to the emergency department.
Well, it's a remarkable program. It clearly leans on the existence of your telemedicine program already in place.
Yes.
And I just point out that Heather just put into the chat, we did do a previous webinar on telemedicine programs, and I think yours was among them. That goes back several years. But could you imagine this working without access to that live physician support?
I certainly could. It depends upon not only, what is within the legal purview of the paramedics, depending upon what state or country, I would imagine, and their comfort, and perhaps, moving past the ED physician who's actively involved during the telemedicine encounter and having direct correlation with the heart failure, in this instance, with this group of patients, the heart failure team. It's certainly possible, but I think it's that collaborative effort between the paramedics who are on scene, doing a lot of the heavy lifting, and the more experienced physicians with regard to making judgment calls regarding increasing dosages or adding certain medications that are then electronically prescribed to the patient's pharmacy, et cetera.
Great, thanks, Michael. I mean, it's an admirable program, and clearly one that many of us would like to be able to emulate. In the closing moments, before I get to Aaron to see if there's, and I haven't been watching the chat very closely, but what we haven't drilled down on a lot here is funding for all of this, as I think most of us would agree that these are wonderful programs. I noticed, Jose, you put something into the chat, which I haven't had the time to read there. What observations do you have about funding even for a program that clearly saves a lot of money like Michael's?
Yeah, absolutely. No, I think that's a fantastic example of how, healthcare system integration into leveraging already existing things can exponentially compound benefit. I think that's a great example. I think one thing that I'm curious about, and obviously this varies whatever program you have. So obviously a lot of these activities save dollars downstream, clearly. The question is, who is saving those dollars? Is it payers that are not paying additional dollars for those services that they would have provided fee for service? Or so who is saving those dollars, and where is those dollars are going to? Because one thing to consider is if a community has to spend more dollars to provide this level of service, but they will not recover or get back any of those savings back into the system to support those programs, then where are those savings staying at? Obviously, I'm making an assumption. I think, Michael, maybe your team is integrated into the hospital system, right? So you have those are already hospital sort of providers or employees or so forth. So the hospital that has a value added benefit because they have targets to hit of readmissions or targets to hit with regards to the penalties for some patients that are highly complicated. Then that makes a lot of sense because they're already on the hook at risk financially for those patients. But in a community where the community paramedic, participants or clinicians are not part of that model, then where are those savings staying, and how are they going to get back embedded into the program? And that's a challenge that is critical for sustainability.
I would just make the observation. So I'm in Canada, Neil is too, a single payer system here, also Ireland. And as the Veterans Administration, I suppose you can make the same claim there. That's a model of a single payer. And as more and more systems move to value-based care, where there is an interest in hitting those markers that you're mentioning, saving system-based money, I think more and more the argument can be made that more and more systems are becoming single-payer systems. Now, we've already done one webinar on financial models, and I noticed that our principal investigator, Dr. Bice, has a comment to make about that, and he was the lead speaker on that panel. So, Kevin, what do you got to say?
No, this is awesome. Thank you, Don. Thank you to the panelists. It's really important conversations. And I guess one practical response to what Jose is saying, because I totally agree with it. Like, the bottom line is the following is not a great deal. Hey, Aaron, I got a great deal for you. If you give me $2, I'll save Michael $10. That doesn't feel great to Aaron, right? And Jose, if you'll forgive, I think that's essentially what you're saying. Like there's a problem with this structure. However, the practical advice then to our clinical champions, who comes to these webinars, is to talk to your financial people and begin to understand how the finances line up for each entity. You got to work your way through that some, and I'm happy to help you think about that. I know others are, but you got to think about the different stakeholders and where the return is. And that's a longer conversation than we have time for now, but there are answers to that. Value-based care, opportunity cost of overfull hospitals. There are answers to that, but you just have to keep in mind that reality of saving one person money doesn't really help the other person unless you can connect those dots. And we're happy to help you think about how to connect those dots. There are more ways to connect them every year, but you got to think about that in advance or it won't work.
One comment about that, similar to, most complex problems, it's usually a robust, multifaceted approach that actually makes it work. With regard to our very specific technologically driven program, the original funding was philanthropy. And then the funding came significantly from the hospital innovations budget, which is really sort of a carve out of their budget. But it's also important to note that about half of the patients are enrolled in our affordable care organization. And so there's savings there through Medicare. And then down the road, we're hoping that we can get some potential reimbursement from the telemedicine component, where the physician is actually connecting with them, so that we can, leverage that, which is already starting to take place. So it's really a multi-pronged approach in terms of the budget and the funding.
And leveraging what I think you mean, accountable care organization, is a really good avenue for what you're just describing. One last comment. If your ER is full, like it is ballooning over, and they can't get people in, there's a financial argument for these models right here, right now, and it has everything to do with opportunity cost. So just know that if you look around to your ER and you're like, oh my God, we can't get anyone in the hospital, all our beds are full, this is a mess, there's an argument to be made to support these programs.
Thank you for that excellent closing comment, Kevin. And unfortunately, we are coming very close to the end here. There are some very good questions in here. One from Todd James, a very basic one of what mechanisms are people using to communicate between emergency departments, in hospital beds, and paramedics. But Aaron, is there any other pressing question that we can answer in a minute?
I think Pat James' question is probably the highest one. The most other ones have been addressed.
Yeah. So, Anne, do you have how do you communicate with from the field to the emergency department? Phone, fax, text?
Thankfully, we've actually moved on from fax here, more or less. So yeah, generally it would be a telephone to ED, and then if it's a GP or something, we would email or phone them.
And are you using a standardized medical record or a standardized health record?
Yeah, we have, but we don't share it. It's a standalone system. It doesn't share.
So brings up an important challenge for implementing something like this. So sadly, we are at the top of the hour. It's 4 o'clock in Toronto. I don't know what it is where you are, but I would like to say a very, if you come to the website webinar subsequently, it's all available here. We have summarized everybody's main points. You can just click through those as I'm talking, Heather. I would like to say a very great thank you to our 5 panelists. They took an hour out of their day and quite a lot more than that to prepare for this. I think we all got some very interesting new answers to the question, what is community paramedicine? It's a lot of different things, and there's a lot of different models that we've seen. And if you, these, as I said, if you come to, there's our blog and our podcast. If in a day or two you want to refresh or get more information about this topic, it will be posted on the GEDC website. Keep going, Heather. And those are all the resources that were mentioned by everybody. Which you don't, next, we've done the Q&A, and just we will be doing another webinar on March 25th. It will be on a clinical topic. So how to address the problems caused by a new class of medication being used to treat Alzheimer's disease. Next slide, please. Next slide. And that's, once again, information about how to join the GEDC. And finally, saying thanks is always an important thing. So our generous funders of the John A. Hartford Foundation and West Health Institute, they help support doing the kind of work that you've seen here today. With that, we'll close off, and with a final thank you to all of our panelists. Bye for now. Actually, if the panelists can stay on for a few more minutes, just for a brief chat, that would be